Yeah. So that's probably the non-osmotic stimulus for her. Yeah, so any not necessarily a malignancy, but any type of infiltrated process of the lungs, either you have like pneumonia or you have like some sort of like atypical infiltrates in the lungs, that in itself is a risk factor for ADH release. So that may explain, if it's not fluid, if it's not volume overload, that may explain like the non-osmotic stimulus. But there are other non-osmotic stimulus. For instance,
what's the mechanism?
It's anything that occupies lesions, anything that occupies space in the lung, it stimulates ADH secretion. I don't know exactly the mechanism, but it's very well established that whenever you admit a patient with pneumonia, look at the labs. There's always some degree of hyponatremia. Like other examples, pregnancy per se, like women, I don't know if you guys have ever been pregnant, but they drink a lot of fluid. And they tend to have a little more ADH circulating than the non-pregnant female. Other examples, for instance, medications is actually the biggest category for SIDH. You guys remember which medications are associated with SIDH? The list is like this long. But lithium causes the opposite. Lithium causes DI, diabetic insipidus. Yeah, it's completely the opposite. But there are like some medications that are very notorious for SIDH. You guys need to know this for your boards. Which ones? Thiazide diuretics. One of the components of the thiazide-induced hyponatremia is SIDH, and that's the reason why we check labs before and after. Remember, we talked about it last week. Which other medications? They're like a big category. You need to know this for your boards.
It's an antipsychotic.
Yeah.
I'm trying to remember. I see the picture in my head.
It's more actually a lot of the psych meds, any centrally active meds, but mostly SSRIs. So you're going to be asked questions about like a patient either taking, how do you call those medications?
She's on
Lexapro. Yeah, definitely. Yeah, definitely. Yeah, Lexapro definitely. So that's the medication that is associated with SSRIs or Prozac, fluoxetine, paroxetine, Paxil, Celexa, you name them all. But some of the antipsychotics, they can also cause it. TCAs are also notorious for SIDH, tricyclic antidepressants. Yeah. Yeah. So TCAs are also notorious for SIDH. NSAIDs. Remember we talked about NSAIDs? I covered like a lot of the renal toxicities of NSAIDs, and one that I didn't mention was the possibility of potentiating ADH effect in the kidney, resulting in SIDH. In fact, NSAIDs is one of the treatments for nephrogenic DI. Remember, there's a central DI and there's a nephrogenic DI. I've never met a nephrologist treating nephrogenic DI with NSAIDs because NSAIDs and nephrologists don't get along. but that's actually one of the treatments because it does potentiate the effect of ADH in the kidneys. So some medications that we commonly use, ARBs actually have been documented to cause SIDH. I don't know, was your patient you said? Yeah. She was on Benicart? Yeah, so what else? Let me think. Tricyclic antidepressants, SSRIs.
The pills do it? The ACE inhibitors also?
No, the pills, believe it or not, it hasn't been that common, but it's more like the ARBs, and I don't really know the mechanistic way, but it's been documented extensively. ARBs causing it. What else? So pain, chronic pain is a non-osmotic stimulus. Anxiety is a non-osmotic stimulus. I don't know if this person is anxious. She's very anxious. Yeah. So anxiety is a very well-known risk factor for non-osmotic ADH release. What else? And understand the fluid intake of your patients. Some patients are habitual drinkers. Some patients do drink a lot of water because they heard in the news, or they just want to be healthy and they do a lot of like water or fluid intake. On average, if your patient has SIDH, you guys know what the management is, right? What is the management? Fluid restriction. It's a water excess problem. It's not a sodium deficiency. Once you understand that concept, it's easy for you to offer recommendations to your patients. It's a water excess problem. It's not a solute deficiency problem. But a lot of times in hyponatremia, you can have a lot of like different physiopathology coexisting in the same patient. Like in this lady, we probably have some elements like she was on an SSRI, she was on an ARB, she was anxious, and she had like these lesions infiltrating the lung. All of those things accounted. But sometimes we see patients that are very frail and they don't have a lot of solute intake. Like I was just telling you last week, she's frail. Yeah, and then this is a typical patient. It's a lady who probably lives by herself. You inquire a little bit about the social situation. If you're by yourself, you're very unlikely to have 3 meals a day, and you're very unlikely to cook, and to eat 3 meals a day. So if you understand a little bit of the background, you need to do that. That's why when I was telling you, if you're gonna think about a thiazide and the patient is already low sodium, probably, and is a frail elderly lady, probably not the best choice, because you know that the sodium is gonna go down. So, but that's another mechanistic way that this patient.
A lot of things going against her.
She got a lot of things going against her, and that's always the case for these patients with hyponatremia.
Now off the meds, her sodium is 132.
It's 132, and is she compliant with fluid restriction? Yeah. So that's another key thing. You need to teach them, because it's very easy to say, but they won't grasp the concept unless you tell them, I want you to buy a 1 liter bottle, and for the whole 24-hour period, you cannot exceed more than 1 liter. And trust me, some patients with true SIDH or severe SIDH, when I say severe SIDH, if you look at the urine osmolality, the urine osmolality can go up as 600 or 700. That means that there's a lot of ADH circulating. So those patients, sometimes they need fluid restriction less than 500 cc's in a day. Go ahead and try to drink less than 500 cc's in a 24-hour period. It's pretty hard. Yeah. So you need to, that's a very important part, because some doctors, for instance, they end up prescribing salt tablets. And I have nothing against it, but if you're dealing with a patient with heart failure or a patient with cirrhosis, the last thing you want to do is to give them salt tablets, right? You need to advise them to just fluid restrict themselves. And that's a very important concept. And it is the hardest behavior to change, by the way. Like,
the drinking intake?
Yeah, to cut down is the hardest behavior, because it's a natural instinct. We all drink, and for them it's difficult to understand the reason why they need to cut down, and that goes against logic, because they've always heard about like drinking is healthy, drinking goes along, with good habits. So, and it's very powerful. The thirst mechanism, Dr. Ben-Zur's patients, they're very thirsty all the time, and you just need to tell them, if you're drinking, you're doing a disservice to your body. When I was at UCLA, it's a crazy story. When I was at UCLA, they used to have fish tanks. They used to have fish tanks in the CCU. All the CCU had beautiful fish tanks. That was at the old hospital. I don't know if you guys have been to the CHS building. It's a very enormous building. It's actually, I heard, it's one of the most complex buildings, besides the Pentagon. It's the second most complex building in the US. Anyway, the old CCU used to be there, and they used to have fish tanks. By the time I started my rotation there, they had taken out, there was only one fish tank left, and it was in the hallway, and they had taken all the fish tanks out. And the reason being, it was a patient, he was drinking, he was not getting better. He had a swan gas catheter, like some time ago, they used to have that pretty standard, everybody had a swan gas, and the guy had like horrible hemodynamics, SVR to the roof, and very, very poor cardiac index. The guy was not getting better. He was peeing 8-7 liters, and nobody understood what the hell, like this, such a severe heart failure, until one of the nurses caught him drinking from the fish tank. So this is a very powerful, people kill for water. It's just that simple. So this is why this disease is very difficult to treat, because you need to do a lot of education. There's no magic about treating this disorder. It's just like you need to be on a 750. If you wanna go right, probably 99% of the time, just tell them 750. They're not gonna like you, but once you explain to them the reason why we do what we do, they're more likely to do it. You need to tell them hyponatremia can increase your risk of falling. I have a physician who's a retired pediatrician. He's doing home hemodialysis, and I see him once a month. The guy's sodium is always low. It's always low. And in dialysis patients, there's only one way that your sodium can go down: if you drink a lot of water. There's only one way, and the guy is anuric. And I kept telling him, like, listen, you need to cut down your water intake. Yeah, I've been like this for a long time. And I explained to him, like, you can fracture, you can fall. And in addition to that, the guy takes all sorts of like stuff that he self-prescribes. I don't even know how he can get away with that. But anyway, so he fell. They just called me 2 days ago that he fell and he dislocated his shoulders. And I'm sure he fell because of hyponatremia. And you can't really assess for those, like, because they're not tangible things, but you need to tell your patients, this is for sure you're gonna fall. For sure you're gonna have an osteoporotic fracture if you're chronically hyponatremic. This guy's sodium was always 129 to 131. So the bottom line, the teaching point for you guys is, if you have an SIDH, a true SIDH, let's say that you did all the workup and you excluded all the other things, because hyponatremia can be, you guys know this from med school, hypervolemic, euvolemic, and hypovolemic. So the hypervolemic, Dr. Ben-Zur deals with it sometimes when you have a patient with decompensating heart failure, or when you guys rotate through the CCU, you see a lot of like hypervolemic hyponatremia. And those patients, you know, because they're in heart failure, and you know because you treat them with Lysis. And they start improving dramatically as they start improving their hemodynamics. We also see hypervolemic hyponatremia in patients with cirrhosis. Cirrhosis is a little tricky. Cirrhosis is a combination of hypervolemic hyponatremia and a lot of like SIDH. But those patients, they tend to be hyponatremic like baseline, and they're very thirsty. They're less likely to be compliant with your recommendation about fluid restriction. So those are like mostly the hypervolemic hyponatremia patients. The hypovolemic hyponatremia, they usually give you a history of whatever, you know, vomiting, nausea, bleeding, you know, like some GI losses or burns. So those patients, we treat them like it's easy to treat because we just give them isotonic saline, and they get better. So, but the big category in hyponatremia are those patients with euvolemic hyponatremia. And for those patients with euvolemic hyponatremia, we use two simple tests to be able to categorize them. One is called the urine osmolality, and I think you guys did it on this patient. Yeah. And the other one is the urine sodium. So those two tests will give you enough information for you to be able to make a diagnosis. So the textbook definition of SIDH is a urine osmolality greater than 100 and a urine sodium at least greater than 40. But sometimes we can see patients with SIDH with a urine osmolality less than 40. And I'm talking about those patients with poor solute intake. If you don't eat a lot of solute, you're not going to pee a lot of solute. That's the way you should remember it. So, but the textbook definition is urine osmolality greater than 100 is suggestive. The higher the urine osmolality, the more likely you're dealing with SIDH. I was just telling you, severe SIDH. I had a patient recently with a urine osmolality of 650. She's on a fluid restriction of 500, and finally her sodium is correcting. But it took me a lot of time to educate the patient and to tell her, teach your patients how to measure that volume, because they're not going to understand. You tell them 32 ounces, they're not going to understand it. You tell them 1 liter, they're not going to understand it. So you just tell them, buy a bottle, this is 1 liter, and you need to account for everything that you drink. Tea, coffee, juice, whatever you drink needs to be accounted for. Even soups, believe it or not. So, but it's a hard recommendation, but that's the treatment. And I'm saying that's the treatment because in the past, we used to treat SIDH. You can still find those treatment recommendations in textbooks, but they're not practical, number one, and long term is not sustainable because all of these medications have side effects. One of the medications they used to use to treat the patients was a tetracycline antibiotic that is not used for antibiotic purposes. It's called dimeclocycline. So dimeclocycline, if you take it for a long time, it does work. I've used it. It does work. But if you use it for a long time, that stuff can cause nephrotoxicity. And it's not the right treatment because if you remember the physiopathy, if it sticks in your brain, it's not a solute deficiency problem, it's a water excess problem. You just need to teach your patient that it shouldn't. And you need to identify what are the possible non-osmotic stimulus that you can correct or you can get rid of. Narcotics, by the way, can also cause SIDH. I forgot to mention that. So the list is this long. I think there's a website called sidh.org or something like that where they have like all the list of categories of medications that are associated with SIDH. But for practical purposes for your boards, they're gonna give you an SSRI because those probably are the more common offenders. Okay, so and then the FDA recently, I'm saying recently, probably like about 2 years ago, they issue a black box warning on these medications, the Vaptans. Have you guys heard about the Vaptans? We also call them the aquaretics. They're not diuretics, they're aquaretics because they make you excrete free water by blocking the ADH receptor in the distal collecting tubules. So this group of medicines, they work very well in the hospital setting, but the black box warning reads that these medications should not be used beyond 30 days because they're associated with severe hepatotoxicity and possible fulminant liver failure. So just to show you another example of why the management is fluid restriction. We have medications that help with that. And by the way, patients with SIDH, they also, if nothing seems to be working, if they have a little bit of SIDH, if they have resistant refractory SIDH, you can give them a little bit of a loop diuretic like Lasix. Let's say that your patient really is Lasix naive and normal renal function. You give them anywhere from 10 milligrams a day or 20 milligrams a day, and that in itself is enough to disrupt the sodium countercurrent that occurs in the loop of Henle, and that's also beneficial for those patients suffering from SIDH. That's another trick that I use for those patients that are not getting better. Just give them a little bit. Yeah, because remember, the thiazides are the ones that cause hyponatremia. But Lasix is used for hypervolemic hyponatremia, and it's also used for SIDH when nothing else seems to work. I usually try, the first approach is fluid restriction. If nothing else seems to work, you can give them a little bit of Lasix. And that also helps. That's one of the treatments of SIDH. So...
No, bring her in tomorrow. It's all
Right now?
No, later.
Yeah, so...
She's going home tonight by herself. She's just staying with her daughter. She's going back home.
Yeah, bring her in and you can give her a little bit of Lasix, a touch of Lasix. That will help her correct. So what are the dangers of correcting someone? You guys know, you guys were asking me when is it safe to send them home. I already told you, never below 120. That's the definition of severe hyponatremia. You cannot defend that in court. Okay to send if you're sure you have a dependable patient and they're not having any symptoms. You can send them out. And for mild hyponatremia, 130 to 135, that's okay. You don't need to admit them. You don't need to worry about too much. It's more like a long-term issue, not like a short-term issue. But why do we worry about hyponatremia so much? You guys remember?
For correcting it?
Yeah.
For the cerebral myelinosis?
Right. So we call it ODS, osmotic demyelination syndrome. They used to call it CMP before. ODS is actually a pretty serious consequence of overcorrecting sodium. So there's two problems associated with sodium, and you guys are gonna get this question. So they're gonna give you a clinical scenario where a young lady, particularly menstruating young females, are at risk of this. If they take ecstasy or any amphetamines for recreational purposes, they usually give them the wrong advice because they tell them like, oh, you're going to be doing a lot of exercise, you need to drink a lot of fluid. Those patients, particularly, like I say, females, especially menstruating females, I don't know the exact mechanism, they have very, very high risk of having hyponatremic induced seizures, and they can actually die. And the reason being is that if the tonicity of your blood, of your serum, goes down acutely, then the brain cells are going to start like swallowing. They're going to get very, very edematous to try to compensate for the drastic change in the serum osmolality. Those patients actually, they develop acute brain edema, and they can actually die very quickly. We had a lady who actually died exactly the same textbook question that I'm telling you about. She was doing ecstasy, and she was told to drink water, and there you go. I had another very disturbing case. I had a patient that came with hyponatremic induced seizure, sodium of 109, and the lady was trying to lose weight. She went to a community doctor. The recommendation, this is a physician, I still don't believe this guy was a physician. The recommendation from that physician was to just drink water and take some diet pill that he prescribed. It turns out that you guys know that a lot of these diet pills are amphetamines, amphetamine derivatives, because they suppress, your hunger sensation. So this lady was told just to drink water, to avoid eating, and just to take the pills. So she started having headaches, and she called the doctor. And the doctor said, like, no, I don't think you're doing the diet correctly. Just keep doing what I told you to do, and just come back this week. The poor lady had a seizure. She went to the hospital, and her sodium was 109. So on your boards, if they give you a patient like water intoxication, for instance, the other clinical scenario they present you on your boards is a marathon runner. Marathon runners, if they're truly professional, they know that they shouldn't just drink water. They should replete the losses with some sort of electrolyte drink. But they're gonna give you a scenario: somebody was running a marathon, drinking, and sure enough, the patient presented with hyponatremic induced seizures. Those patients acutely, we manage them with hypertonic saline. We try to bring them. That's how you stop the seizures. You give them 3% saline. And supposedly you're not even supposed to wait for the labs to come back, because most labs take about an hour to give you the results. But if they give you a history of, like, this guy was running and he started having seizures, you're supposed to give him hypertonic saline, 3%. You're supposed to correct 10% of the presenting sodium, 10% immediately, to be able to help them, to get them out of the danger zone. So for your boards, if they give you such a scenario, that guy was running and he started seizing, the correct answer is 3% saline, hypertonic saline. Okay, so that's the danger with acute hyponatremia, either because you have a person like drinking like crazy, like a water intoxication, or a marathon runner, or like an ecstasy type of situation. So, or there is another type of clinical scenario they may give you when they do a TURP. You guys know what a TURP is? Transurethral resection of the prostate. Urologists are supposed to measure the amount of irrigation fluid they give, and they're supposed to measure the amount of fluid that goes in, and supposed to measure the amount of fluid goes out. This fluid is isotonic, but it's hypotonic. It's iso smaller, but it's hypotonic compared to the serum. They use, I think it's called glycine. I think that's what they use. So when I was in training, I was a fellow. One of the surgical persons called me. It's funny how he told me, like, I'm calling you with the mother of all renal consults. I didn't know what he meant, until he truly showed me that this patient's sodium was 88. I've never seen anything like that. It was 88. He sees on the table, they send lights, and he had like the TURP syndrome, which is translocation of hyponatremia. So those patients, you try to bring them quickly, because at least you know when the problem happened. The problem is when you don't know how long the sodium has been low. If you don't know how long the sodium has been low, you need to assume that this patient has chronic hyponatremia. The textbook definition of chronic hyponatremia is when the hyponatremia has been there for more than 48 hours. So again, I'm going to repeat this because this is an important concept, how you manage sodium. If the sodium drop happens acutely, it's okay to bring them up acutely. If you don't know the duration of hyponatremia, you have to assume it's chronic hyponatremia. That's an important concept. So why is this important? Because after 48 hours, there are a lot of changes that happen in the brain. The brain starts releasing like amino acids and all sorts of like osmotically active substances to try to compensate for the hypotonic serum. The problem is that if you bring them very quickly, or if you correct them very quickly, they're not going to have enough time, and the cells are going to start like lysing. The brain cells are going to start lysing, and that's when the problem happens. And one of the interesting things about this syndrome, the damage doesn't happen right away. Damage can range anywhere from days to weeks. Like a hyponatremia case that was reviewed when I was a fellow, the patient developed like damage, presented with neurological damage 3 weeks after the correction. So that's why if the patient is going to be fine, he feels fine, we can just correct him. It doesn't happen that way. The damage can happen long term. And one of the very ominous complications is called locked-in syndrome. Have you guys heard about locked-in syndrome? So that's one of the complications of hyponatremia. Like in the 1990s, all of you where I used to work, they settled like a multi-million-dollar lawsuit. A nursing home patient ended up developing locked-in syndrome as a result of overcorrection of hyponatremia. So for that reason, there are very specific guidelines in how quickly you need to correct these patients. If you want to be 100% textbook, and there's no way no one can actually get you in trouble, they recommend that you do 8 points in a 24-hour period. I usually, my comfort zone goes up to 10 points in a 24-hour period, but generally speaking, no more than 8. And I'm bringing your attention because SIDH, you guys have to remember that the half-life of ADH is very short. Like, I don't know if you've seen in the hospital setting, why do we use ADH for, by the way? Why do we use ADH in the hospital setting? The ADH is a drug, right? Vasopressin. In which clinical scenarios we use vasopressin? What are the therapeutic
Is
uses?
it a nephrogenic or neurogenic issue?
Well, you use it when somebody has DI.
Yeah.
That's the treatment of choice when you have DI. But we also use it, or at least surgeons, cardiothoracic surgeons, they use it because ADH also enhances the release of the von Willebrand factor. So the patients, they tend to be less coagulopathic after major cardiothoracic surgery. So that they use it in that setting. Surgeons generally use it, but like the half-life is very short, it's about 4 hours. So it's important that you guys understand that, because let's say that you admit a patient and the sodium is 122. Let's say that let's play with this lady. She's 122, she went to the hospital, she's having a lot of symptoms, coordination issues like nausea, headaches, and then you establish the diagnosis, you say, yes, this lady has IDH, and you identify the reasons. Okay, she's taking an SSRI, she's in a lot of pain, and I'm going to control the pain better. She's very anxious, I'm going to make her feel better, I'm going to reassure her. And then I'm going to start treating her pneumonia. Let's say that you start doing all those things at the same time. So you're getting rid of all those non-osmotic stimulus. And the patients, once the non-osmotic stimulus, they wear off, the ADH also wears off. And the patients, they start peeing like crazy. I don't know if you've ever seen that, but take a look at the Foley. Most patients in the hospital, they have a Foley. And you can see they're urinating pure water. Pure water. So when I was an intern and just trying to understand this concept, like, what do you mean, like they're peeing a lot? I mean, they don't look volume overload. They're not volume overloaded. It's just free water that they were able to hold on to because of the effects of ADH. And the urine, when you look at the urine bag and you see a very dark color urine, you know that urine is very concentrated. That's the urine when someone is dehydrated or when someone has a lot of ADH on board. You look at the urine, it looks very concentrated. Once you get rid of that stimulus, the urine looks completely water-like. And if you measure the urine osmolality of that urine, is very low. It's even less than 100 sometimes. And the urine sodium is very low because they're peeing like a horse. I mean, it literally. So if you're treating someone with hyponatremia and they start going in the polyuric phase, please make sure that you understand what you're doing, because the textbook definition requires that you follow sodiums anywhere from every 2 to every 4 hours to avoid overcorrection. So that's one of the signs of overcorrection, when they start like urinating a very dilute urine. So that's number one. So that's the reason why with SIDH, patients can get in trouble if you don't know what you're doing. Because you admit them to the hospital and then you forget about the sodium until the next day, and then the next day the sodium is 135. You overcorrected 13 points. So then you need to, what the right thing to do is to try to induce, we call that therapeutic induction of hyponatremia, to at least prove that you try to do something about it. Because if you don't do anything and you discharge the patient home, chances are you're going to be fine, but you don't want to be discharging that patient home unless you understood what you were doing. If the patient, that's one of the dangers of SIDH. So on your boards, I don't think they're going to ask you the more or less the overcorrection, but they're going to ask you, the ODS, previously or formerly known as central demyelinating CPM, something like that, yeah.
Myelinosis.
Right. So yeah, so make sure you guys know that. But SIDH, the outpatient management is pretty straightforward, but the inpatient management can be tricky, because if they go on the polyuric phase, you have to be on top of those patients. That's actually, I hate getting a hyponatremia patient in the middle of the night, because I know nobody's going to pay attention, and after they call you, the patient, you own the patient. So, but you can't go wrong if you measure the urine output. And like, let me ask you a question and see if you understand the concept. This patient has SIDH, and 100% guaranteed that the patient is not drinking. 100%. I'm giving you a very hypothetical scenario, because most patients drink, but the patient is not drinking any water, and you admitted the patient. Can the patient's sodium keep going down?
And they were...
You admitted the patient, let's say sodium is 117. And you're pretty sure the patient has SIDH, looks euvolemic, urine osmolality of 300, urine sodium of 50, and...
You don't know the answer on boards, that's just a good, The answer is yes. Yeah.
Can the sodium keep going down?
Yes.
Only if you had a lot of water in your stomach that we didn't account for. Like let's say the patient drank and I measure and then that water got absorbed. But let's say the stomach is empty and your patient has true SIDH, the sodium is not going to keep going down. Because remember, it's a water excess problem. It's a water excess problem. So that's when I have a patient with SIDH and the nurses call me, doctor, the sodium is going down, it's 112. What should we do? I know already that the patient is drinking. There's no other way. There's no way of explaining. For the fifth time. That's a crazy story, but it's a real story. It's a crazy story.
You talk about hyperkalemia, new therapy.
Hyperkalemia, yeah. So basically have that in mind. It's a water excess problem. Okay? Water excess problem.
But that's only for euvolemic patients?
For true SIDH.
Okay.
Yeah. So if they have a hypervolemic, that's a different story. But yeah, for true SIDH, it's the management is fluid restriction and the risk of inpatient is overcorrection. Okay. So hyperkalemia. So hyperkalemia, guys, you guys know is a big topic on your boards. You're gonna get a lot of questions about hyperkalemia. The easy way to remember it is, what are the causes of hypernatremia? Just always think about like for everything in medicine. If you have a methodical, like a structured way of thinking, you're gonna remember your differential and you're not gonna miss important things. So hyperkalemia can either be from overproduction. You guys know which scenarios are associated with overproduction of potassium?
Is that?
Two board favors. I'm gonna give you like the board favors. I'm not gonna give you zebras. So.
Addison's, right?
No. Well, Addison's can be hyperkalemic, but from aldosterone, from hypoaldosteronism, from aldosterone deficiency, but not for overproduction. So overproduction for the boards, rhabdo, typical. They found the patient down, or a woman that was having a status epilepticus, or some patient that had a weird position. I actually got called one time with a consult like in the PAC here in the post anesthesia recovery unit, and I went to see a patient, bad renal failure, and then I always send a CPK when I'm consulted for an acute kidney injury. And to my surprise, the lady's CPK was greater than 80,000. I was like, what happened here? So you can get anesthesia related. It's like an idiosyncratic type of reaction, but you can also get it in the post-op period from awkward like positioning, like the leg. And this is probably what happened with this patient. The leg got somehow caught, and that causes a lot of like rhabdomyolysis. So overproduction, always think about rhabdo and think about hemolytic anemias. So if you see a patient with a lot of potassium, that's probably part of your differential. You need to make sure you rule that out. So those are probably the two most common scenarios. So the other big category is the translocational hyperkalemia. We all know that the potassium is supposed to be an intracellular ion, right? So there are some clinical scenarios where the potassium is shifted from the intracellular space to the extracellular space. You guys remember some of those scenarios?
From the intro to the extra?
Metabolic acidosis? Yeah.
Excellent. Metabolic acidosis, that's actually one of the most common causes. Insulin deficiency is another common, and that's the reason why your patients, when they present with DKA, they're usually hypokalemic, but then they start becoming hyperkalemic. What's that? ACE inhibitors, yes, that's decreased clearance. I'm going to talk about another big category. But translocational happens in those two settings mostly. You can also get in the respiratory acidosis, but that's less commonly seen. But it's mostly metabolic acidosis, insulin deficient states. Yeah, so those are the two big categories. Then decreased clearance. Who's responsible for potassium clearance in the kidney and in the body? I told you the answer. The kidneys, right? So about 90+% of the potassium clearance happens in the kidneys. Some of that clearance happens in the gut, and that's why it's important if you have kidney disease patients, you ask them if they're constipated, because they shouldn't be constipated, because the gut, some adaptive mechanisms Patients with advanced kidney disease, the gut participates more in potassium clearance. So make sure you always inquire about constipation in your chronic kidney disease patients. And we covered the foods. I see 2 new faces here, but you guys remember what are the foods high in potassium? Avocados. What else? Bananas. Potatoes. Very good. What else?
Squash, right?
Squash. A lot of the red, orange fruits, papaya, mangoes. Yeah. So coconut drinks, coconut water is big. Is a big category. Seaweed, molasses. Yeah. So make sure you guys potatoes, tomatoes, avocados, beans. So you need to know this because you don't wanna miss the diet aspect, especially when you prescribe this group of medicines. Can you do me a favor? Oh, maybe you can help me connect my computer here.
Oh, yeah.
Yeah. So, okay. So decreased clearance, overproduction, translocation of hyperkalemia, and there's a big category called pseudo hyperkalemia. And when do you think this happens? Pseudo hyperkalemia. We see this in clinical practice. I see it all the time. So pseudo hyperkalemia is a diagnosis of exclusion when you rule out other things, but typically it's a patient with normal renal function with no clear reason to have hypotassium, and then you ask the patient, you ask the lab to do the labs without a tourniquet, and the potassium is normal. So there's a lot of lysing of the red blood cells, especially in the labs where they have like student phlebotomies. They're learning. And you see this quite common in clinical practice. So if you have a high potassium, you have no good reason to have a high potassium. Remember the homeostasis of potassium is pretty tightly regulated. By the same token, if you have low potassium, you're kind of obligated to investigate why does this patient have low potassium. Same thing with high potassium. Why does this patient? But we also see pseudo hyperkalemia in the setting of like hematologic malignancies, like patients with platelet clumping. That's like a falsely elevated potassium. So it really has no clinical implications in terms of management, but you need to document the reason so you don't chase your tail like doing workup, that unnecessary workup. So okay, yeah.
I'm sorry, I didn't really understand the phlebotomist.
Destruction of the membranes of the red blood cells, and lysing and release of potassium. Yeah. So it's quite common. So make sure you guys. If it doesn't make any sense, just tell the patient next time you're gonna tell him to get the blood draw without a tourniquet. I got a patient that he was so grateful. It's a guy with interstitial lung disease, sent to me for hyperkalemia, and that's all I did. I just sent him to the lab and told him, do not use a tourniquet. The guy, he was so appreciative. He told me like, you have no idea what this mess for the last year they caused. Like I had to stop. I'm already dying from this lung disease. And they told me to stay away from everything that I loved to eat. It's a big deal. It's not a big deal in terms of like outcome, but it's a big deal for the patients, because why are you going to restrict their potassium intake if they don't have to? So if you don't have an explanation, you do all the workup. Pseudo hyperkalemia is part of the differential diagnosis. Okay. So management of hyperkalemia. So the most important thing is to identify what is the physiopath behind. If it's hemolysis, you already know. Sometimes when the hyperkalemia is so severe, we just have to dialyze the patients. But before we get to that, there are multiple strategies that we can do in the hospital setting. I'm going to talk about strategies in the hospital setting and in the outpatient setting. In the hospital setting, usually you identify what is the cause. If it's hemolysis, you can play around with medicines. We very commonly use Kayexalate, which is a binder, a resin binder that binds potassium in the gut, and patients hate to take that medicine because it causes a lot of diarrhea. But that's pretty commonly used. What are the contraindications of using Kayexalate? You guys know what are the absolute contraindications and relative contraindications?
Can you repeat the name of the medication?
Kayexalate is also known as Keonex or sodium potassium polysaccharide, I think is the name of it. Do you guys have Hippocrates? Yeah. So do you guys know what the absolute contraindications? So make sure you know that, because all doctors use it like candy, and you can actually hurt people with Kayexalate. So if you have a post-surgical state or ileus, or any type of obstruction, you do not use Kayexalate, because Kayexalate, before they used to combine it with sorbitol. There was a preparation associated with sorbitol, which is osmotic laxative, to enhance the effects of Kayexalate. More and more case reports came up about intestinal necrosis. So by definition, you do not use Kayexalate in somebody with questionable intestinal motility, because it's dangerous. So that's one thing. So in the hospital setting, we use other things, like in that order of ideas that we talk about, like translocational, insulin deficiency. That's the reason why we stimulate insulin production by giving the patients D5. So if you have a patient that is not in DKA or a severe uncontrolled diabetes, you give them D5, and that stimulates endogenous insulin production, and that also brings down potassium. So you can give them a little bit of, like, let's say D5 half NS or D5 NS, and that helps with shifting potassium to the intracellular space. You give them insulin. That's another common strategy for the same thing. It causes translocation of the potassium. We use beta-2 agonists in the hospital setting, because beta-2 also cause shifting of the potassium from the extracellular to the intracellular space. You guys know albuterol, right? Yeah, albuterol, we use it obviously for COPD, asthma, any type of lung issues, but we also use it for hyperkalemia. And I think OB doctors, they use it a lot for preterm labor. What do they use it for? It's to stop preterm labor. It's actually how do you call it? Tocolytic. That's how they call it, tocolytic. Okay, so that's another strategy that we use. If the patient is acidotic, sometimes doctors give bicarbonate. Bicarbonate uses the same thing, your correction of acidosis, shifting of the potassium from the extracellular to intracellular space. How do you prescribe bicarbonate in the hospital? You guys remember how do you prescribe bicarbonate in the hospital? So you can either give an amp, each amp has 15 milliequivalents of bicarbonate, sodium bicarbonate, or you can ask the pharmacist to prepare an isotonic bicarbonate drip by mixing 1 liter of sterile water with 3 amps of sodium bicarbonate. And remember I told you 50 milliequivalents roughly, 50, 50, 50, that's 150. That's very close to isotonic saline, which is 154. So that's how you do it. I always tell students and residents, fellows, if you're going to prescribe sodium bicarbonate infusion, understand what are the possible complications of a sodium bicarbonate. Everything has a complication, right guys? If you prescribe normal saline, you can induce stuff. Same thing happens with sodium bicarbonate. If somebody has like severely hypertensive, you're going to become more hypertensive. If your patient has hypocalcemia, they can become severely hypocalcemic if you give them sodium bicarbonate. So it's a relative contraindication for using sodium bicarbonate intravenously. And if the patient has hypokalemia, you can actually kill someone if you give them sodium bicarbonate. I'm going to tell you a story from my training days. An HIV enteropathy patient presented with chronic diarrhea and with a non-gap acidosis with a potassium of 2.8 and a bicarbonate of 10. So the patient, the team that admitted the patient, they failed to recognize that the most important electrolyte abnormality was not the metabolic acidosis. They all got excited because they realized, like, oh my gosh, this guy's bicarbonate is 10, but he was compensating just fine. Like we always talk about anemia, patients walking around with a hemoglobin of 4, or like a pericardial effusion, chronic pericardial effusion versus an acute. Same thing happens with chronic metabolic acidosis. He was just fine. So the team failed to recognize that the problem was not the low potassium. They thought, oh, the problem is actually the low bicarbonate. So they put the patient on a bicarbonate drip. The next thing that happened is the patient coded. He didn't die, but it was a totally avoidable complication. So you want to replete potassium before you correct hypokalemia, because hypokalemia is expected. It's not even a side effect. It's an expected outcome of giving someone sodium bicarbonate intravenously. So you make sure that you follow that electrolyte very closely. Okay, So that's another strategy in the inpatient setting. And last resort is dialysis. I've had to do dialysis in patients that they're still making urine when there's nothing else that you can do to bring down the potassium, and they have a life-threatening emergency. And I'm saying life-threatening by EKG abnormalities or like conduction abnormalities. So always a good concept that you guys understand is dialysis requires some preparation. It's not like, oh, I need dialysis, I'm going to give you dialysis right now. We need to put a line, and we need to make sure that line is functioning, especially if it's a net line. I need to do an x-ray, make sure that there's no pneumothorax or the line is not, in some other place. So you have to understand that the minute that you call the doctor to put the line, by the time the line is in, by the time it's confirmed the position, and by the time they're able to prime the machine and they're able to start the patient on dialysis, there's some time. Probably in the best scenario is about 2 hours. Probably in the UCLA CCU we can get it probably within an hour, but there's some time. So it's almost never the treatment right away, but it's a possibility. Single pass dialysis, there's different types of dialysis. If you rotate through tertiary center, you're going to see something called CRT. It's continuous renal replacement therapy, versus single pass, which is the bedside machine that the technician goes in and it gives bedside dialysis. Single pass dialysis is a lot more effective correcting hyperkalemia than any other types of dialysis, than compared to peritoneal dialysis or compared to CRT. But that's how we, in the hospital setting, that's how we do it, especially in a patient with, I mentioned hemolytic anemias, rhabdo, and now that I remember, another clinical scenario that you guys are gonna get on your boards, guaranteed, is a patient with tumor lysis syndrome. Have you guys got any questions when you're practicing about tumor lysis? So who gets tumor lysis syndrome? You guys remember? People on chemo, especially like hematologic malignancies, like patients with a large tumor burden. Like let's say they have like a large B cell lymphoma with bone marrow infiltration, like a lot of tumor burden. They get tumor lysis, and tumor lysis is manifested by acute renal failure, hyperkalemia, hyperphosphatemia, and hyperuricemia. So if they give you those hints, you know that you're dealing with tumor lysis. Or in anticipation, like the prophylaxis that we do for these patients, we give them some allopurinol, and then we start treating them with